2 minutes. We'll get started again in about 2 minutes, so if there's folks out in the hallway that are coming back in for the town meeting, I encourage you to come find a seat. Thank you. I'll pitch it to you, but we won't start. Okay, welcome back. We have, I'm just going to start by allowing the GLHC leadership team to introduce themselves and tell you a little bit about them, and then my intention is to turn right to you. And so this is your opportunity again to compliment us, challenge us, ask questions that you would like to have answers to that you think could be of use to the rest of the audience here today. We'll take all comers. The one thing that I would ask is that Emma Lilly, my colleague over here, has a microphone. I've got a microphone over here. We are live casting the town hall meeting, and so in order to make sure that the audience, our virtual audience, can follow along, please wait for one of the microphones to get to you, okay? Okay. Doug, would you start?
Sure. Doug Dietzman, as you heard, Executive Director for Great Lakes Health Connect, and been with the organization, which I didn't mention before, back 2009.
I'm Julie Clausing, and I'm the Senior Director of Program and Technical Operations, and I've been with Great Lakes Health Connect since 2010.
2 words: consent management.
Okay.
Go.
I can probably go a long time. So let me say it this way. If you think about HIE in 2 halves, there's the push world and the pull world. When we're in the push world and we're talking about notifications of referrals, pushing referrals from one place to another, clinical exchange through direct or other means of push, since it's directed from one person going to another, it really follows today's consent model. So if I'm authorized to be able to fax it or to courier it or to put it on the foot of a pigeon and send it out the window, then sending it via the HIE tools is similar. It's just another mode of doing it to the extent that I have the ability in today's consent. We talk about query, that's when everything gets all messy. Because now someone is putting data in the middle for a time in which somebody wants to query and say, what do you know about Doug? Under today's HIPAA rules that we govern, if it's for treatment, payment, or operations, so in this case treatment, or if you're in a care management type function and you're helping support those sorts of things, it may fall under operation. But then being able to query that record is perfectly okay for the physical health world. That's, as Mandy talked about, we get into the behavioral health and what has to be specifically. There's some of that data that we don't take in today because we don't have a good model by which we can determine whether the person asking actually has permission or not to view it based on what was written on a piece of paper in someone else's office. So those are some things we're hoping change. But from a pure consent standpoint, typically in the push world, it just follows today's. In the pull world, it's the physical health stuff based on that treatment operations. And then if a patient wants to opt out of that query world, then they can come to us and we will make sure their information isn't viewed by any place. So did that get it?
No, it's going for the behavioral health side. So
The behavioral health side?
yeah.
It be shared. So again, in the push world, pushing a complete record to somebody who is entitled to see it isn't a problem. But when we talk about patients who just move around and we want the data available wherever they happen to show up, It's just not feasible technically today, based on, at least in Michigan, what the consent laws are, to be able to put that data in the middle and then properly manage, because it's not on the person who's asking in the behavioral health, it's on the person who had the consent as to whether they can even send it kind of in the first place. And so even some of the EMR vendors in that space, to the extent that like a PCE Systems is holding and managing their behavioral health data, that if we have a query into the
Could any of you speak to any involvement you may have at the national level? I understand that you're privately funded. That's great, but how can you? Who's all involved at the national level, helping to influence some of the major decision makers with some of the great things that you're doing?
A couple different things. I think we are, and particularly in the last little bit, in relation to our involvement in Flint, have gotten a lot more visibility within the Office of National Coordinator, including Karen before she left, and now Dr. Washington is the head of ONC. So we'll need to get to know him, but that team is more aware of us. I serve on the board. There's an organization, the Strategic Health Information Exchange Collaborative, affectionately known as SHEIC, that is a trade association of health information exchange organizations. And I think one of our biggest concerns or challenges is HIE almost means nothing anymore. It means everything, like I said this morning. And so who is talking a lot in DC are the vendors with what HIE means in their context, or the hospital association is there from an enterprise standpoint and kind of what individual organizations are doing relative to health information exchange. But there hasn't been anybody in DC talking about organizations like us and the role we play, where vendor HIE is great in its context. Enterprise HIE is absolutely necessary for them kind of doing their business, but when we're talking about community-based stuff that supports the public, we're kind of afraid that message is getting lost a little bit. So I'm on the board of that organization, and we're, as things come out that we can respond to, or as we can push the agenda, that's another avenue that we're personally involved with to try and move things down there. It's an interesting challenge, but we're in the game.
So, Doug, how far out are we from the snowbird going down to Florida, going into the ER and having their records available from here?
Well, not to pass the buck, but I'm going to pass the buck. Julie, as part of the SHEIC organization, there's a particular initiative called the Patient-Centered Data Home. So I'm going to have her describe that, and then we'll link it to your question pretty specifically.
Yeah, so we're participating in a pilot as part of SHEIC, and there's 7 HIEs kind of across the country, sort of in the middle of the country, that we're working with to share data as far as ADT data and CCD kind of patient summary sort of data, so that if I as a patient am in Kentucky and need to go to the ED, hit my head on a cave wall or something like that, then my patient-centered data home, of course, is Michigan, is GLHC, and so based on my zip code of where I reside, they know to let GLHC send them an ADT saying, hey, we've got your patient, Julie Clausing, and then they can also request like a patient summary, CCD, back to them so they can have some of my history available to care for me appropriately down when I'm in Kentucky. And then vice versa, from the GLHC side, our providers that know me and care for me here in Michigan can then request a care summary back from the Kentucky folks when I get discharged or whatnot. So that's kind of the essence of what we're putting together. And like I said, it's 7 HIEs. They're also doing a similar thing this is part of SHEIC in the western kind of states here too. So
yeah, I think so. As exchange networks, and we're talking about how do we connect nationally and how do we get some national network going. The thought is that we as exchange organizations that have already built these networks, if we can figure out a way to connect ourselves in a meaningful way, which as Julie said, if someone from another territory comes in and based on the zip code of their home, I know that they have a home someplace else, it informs us better and lets them know what's going on, that we can, HIE out there is going to send us a notification to say, hey, this individual just showed up, and by the way, do you have anything to inform us? And then it gives us the ability to reach out after and say, hey, what happened in Arizona, so that we're both up to date, kind of on both sides of that equation. So in a state like Arizona where they have an HIE, that's how we do it. When you go down to Florida, Florida doesn't have a mature exchange down there that we could tap into that way. But there's nothing to say that we couldn't go to a Baycare, who I know is a Medicity customer that we leverage some of their tools, and also have good relationships with one or two of the hospitals here, and say, hey, why don't we do that with you as a health system? You tell us what your kind of primary service area is down there. If we have somebody show up here in Michigan, we'll let you know. If you have somebody from Michigan show up down there in your hospital, you let us know, and start to use that as a model where we can, at some level, on a query basis, start to build the ability to have that for the snowbirds too. I've always felt like we were pretty far away in the query world from being able to do that on a national level, but with some of these initiatives now that we're piloting out, if we can figure out how to make this thing work, then I think we've got a really strong chance to be able to enable that where there are mature networks that we can connect into.
Doug, are you looking to promote your Viper as a product that other states can use as a revenue source? Can you generate revenue on your Viper, which is kind of your own product, which you can sell or?
Well, so we have two primary platforms in the back end. Medicity is one which I mentioned, and what we call Viper, have branded that internal to Michigan, they call Pro Access. So that is a product that we've licensed from them, and then we are making available to our participants. So we wouldn't have any ability to take that and sell it anyplace. We're also using InterSystems as a service bus for the technical geeks, if you know any of that, which is another kind of component of what we're doing. So licensing it as a product, no. When you ask, are we focused on going outside the state potentially or extending beyond, I think the board has always had a opportunistic, if there are opportunities, great, but we don't have a focus. We're focused on Michigan, and there's a lot of work here just to get our own communities connected before we worry about kind of extending beyond. And when you think about our borders, Ohio has a pretty mature exchange thing going on there. They're also using Medicity, so part of what we've been talking to them about is just the way Epic can talk to other Epics. If Ohio is right across the stinking border, then why can't we get access to their record and vice versa as patients are moving across, so that we look like a single record, even if physically it's not. So that's one thing we're working on with them. And then you come across further in the south, and you got Indiana down there, and the South Bend area has Michiana Health Information Network that is a strong local provider, and then of course Indiana Health Information Exchange is one of the 10-year-old plus guys that have been around a long time. So we don't see those natural extensions that would just kind of take us across, and in any case, there's, as I said, plenty of work yet to be done right here.
I'll jump in real quick with one of the prepared questions, but first I'll move out of the way of that speaker so it's not feeding back. George, this is something that was submitted, and I know that's something that our implementation consultants hear quite a bit, is that GLHC, and I'm the marketing guy, so I'm going to plug, we are the largest health information exchange in Michigan. We're connected to 129 hospitals statewide and 4,000 plus provider offices, primary specialty, and allied care. What do you see on the horizon in terms of where our growth is going to be coming from as we move forward, and what kinds of targets from a business development perspective do you see the organization moving toward?
Yeah, so today we do have 129 inpatient settings connected, 4,000 community organizations, whether that be provider offices or skilled nursing facilities. Really, there's only a few inpatient settings left in the Lower Peninsula that we currently don't work with on some level or another. So I don't really want to be measured on our growth in the hospital setting, but that community, creating the care-connected community that we're looking to do is that skilled nursing long-term care facility, and we're building partnerships in that area, and recently just signed one with Leading Age Michigan, also with a vendor that has a large market share in that skilled nursing facility so that we can grow that network. Also with the Michigan Primary Care Association, we see that as a great partnership, and that is a volume-based area outside of that inpatient setting that we can take a big bite out of for the state of Michigan. BHPI, who's another partner here, in the behavioral health setting, how do we tie all of those? So I think where we see our areas of growth are in the diversity of individual organizations and groups of organizations that touch patients across that care continuum. We'll certainly always have a large focus on that inpatient setting and continue to grow and add services there. But really where my team and myself, where I spend my time, is a lot of those secondary PO, physician level groups, statewide organizations on the FQHCs, in behavioral health and in the skilled nursing long-term care facilities. So really that's where I see our growth coming. It's a larger challenge. You're taking a lot of small bites instead of a few very large ones, but we have a great technical team that has come up with some good efficiencies. We're working on pricing for a lot of those individuals to make it more palatable, and have shown, I think, some pretty good successes, particularly over the last 6 months in those areas.
Yeah, that's great. We got that on tape. So, the one thing I'll mention that wasn't, that I think still has potential for us and would love to get into is working more with the plans. And I think because of the insurance exchange and just everything that's gone on over the last number of years with Medicaid rebid, lots of different stuff, the plans have just been really absorbed in trying to figure out how to respond to that sort of thing. And the health information exchange has been more of kind of a secondary item. And yet I think that a lot of what we do is specifically geared toward helping the providers in those networks achieve the incentives and achieve the goals that the plans are looking for them to achieve. So I'm kind of hopeful over the next little bit that as some of that other stuff starts to calm down and it's not quite so much change in the plan space, that we'll have the opportunity to talk a little bit more there and see how we can help them again be successful with what they're trying to accomplish in their spaces too.
Great.
With that, can you talk about then your relationship with MyHIN and, for example, the Blue Cross Blue Shield pay for performance requirements initiatives?
Mm-hmm. Sure. So we're on the MyHIN board. We have been involved with MyHIN. Well, we existed before they did, but have been involved with their development back to the very beginning. I think that there's increasing confusion as to kind of what the roles of the organizations are. If I take you back to kind of how things got started, Michigan's operational and strategic plan defined 9 medical trading areas that would each have its own health information exchange that was assumed to be equally viable, equally sized, equally functional in what they offered, and therefore needed something in the middle to kind of help coordinate those activities. What's happened over the last 6 or however many years is that reality, that didn't turn out the way it was originally planned. GLHC kind of blew that up a little bit when we had some of the larger health systems like a Trinity or a McLaren, Ascension say, well, we're not going to do 9 of these things because we have hospitals. We're going to do 1 And so their involvement kind of pushed us beyond some of the traditional geographic boundaries. So I think our relationship, getting back to the question with that context, we have always, and I don't think there's anybody who has successfully implemented more of the MyHIN use cases in what needs to be submitted, whether it was for meaningful use or the Blue Cross Blue Shield requirements. I think as it relates specifically to the Blue Cross requirements, we typically don't find out about them until our participants do. And there's usually 3 months before they're on the hook to lose millions of dollars if we don't respond in some Herculean way to help them achieve that. So, but we're committed.
And with another one of the questions that was submitted and get Craig into the game. Craig, that you can hardly open a newspaper or look online at the news and not run into an issue about cybersecurity today, particularly in healthcare. There's been a couple of pretty high-profile stories in the last few weeks or so. I know that it's a question that we get fairly regularly. Could you speak a little bit to the security protocols that GLHC employs to make sure that the data that we manage is safe?
Sure. Well, I think with any security profile, it's really looking at a multifaceted approach. And part of our philosophy really begins with policies and procedures. Having policies and procedures in place really drives your solutions, what profiles that you need to maintain and secure. So, we look at it from a configuration management perspective, from our server infrastructure to patch management to vulnerability management. You have to really connect all those dots. And obviously from a malware perspective, bringing in solutions that also, safeguard your desktops or your laptops, your mobile devices, all of those different solutions. And to our discussion earlier this morning regarding kind of that one-size-all approach, it really doesn't fit as far as security goes. But I think at the core, it's really about, do you have a policy and multiple policies and procedures in place that helps guide you to that point that you're going to initiate those procedures and safeguards within your system. So, from a team perspective, from an IT perspective within our group, we obviously have wonderful team members that, support that initiative, a privacy and security officer that helps drive those as well, keeps me on track and says, hey, yeah, I know you want to go follow that shiny object or that squirrel, but come back and let's get you back on track, and we need to safeguard the data and patient information that's in our environment. So too, do we have to make sure that we're securing our employees' laptops and mobile devices, and so there's strategies obviously that we put in place to ensure that as well. Now, granted, I'm not always the most, I'm not a person that people say, hey, you're going to put this new protocol in place. So I'm maybe not always the guy that gets the big high fives in the room, but at the same time, it's also about making sure that we're secure and that patient data is secure as well.
I'll give you a high five.
All right, thank you.
Because if there's one thing that messes us up, faster, it's going to be something in this area. So, Craig and his team working really hard. And to bring Banner back into it, did you guys see the breach at Banner from like a week and a half or so ago, where they got into the PHI from the food point of sale system? So that somehow they got into the point of sale system in the cafeteria, but because they didn't have their network segmented, the corporate environment from the data environment, they were able to get all the way from the point of sale system into the PHI, and that's how the breach occurred. Now, Craig and his team, with Lisa Miraz, who's our security officer, were already all over making sure that we had our environments separated so that if someone, for whatever reason, despite our advanced ransomware and all the other stuff that they're doing that I think sounds cool, if they happen to get into the corporate side, you can't penetrate over into the other, just to make sure that as much as you can't get 100% secure ever, but to the extent that we're doing everything we possibly can to put the protections through policy, procedures, technology, divisions of things in place, that's what we're working on doing.
Others? Okay, I'm going to lob this one up. I've got another one that was submitted here, and the question is,
So it's a very good question, and in the different areas that we deal with, meds is hard, because everybody has a little, and nobody kind of has it all. I think that we know what a person has and can kind of reconcile through all that. Electronically, it's been a challenge for us. You have the SureScripts network. Doctor First uses SureScripts kind of in the background as well. Those electronic networks don't have it all, because if you go to walk out of the doctor's office with a piece of paper, that's not being electronically prescribed, so they may get it when it becomes a claim someday and comes back. If you go and get the free antibiotics or the $2, $3, $4 copay things at the pharmacy, those things typically aren't getting routed kind of to the same spot either. And then for those that do have a med history service that we could leverage and try and make available to you all, they kind of understand that it's valuable. And so it's a small mint to pay for the thing, really cost prohibitive to kind of try and make that available. And then I'll just end with that the med reconciliation process itself often gets talked about as a technology process. It's really, I don't think you can get around it being a human process. It can be a technology-enabled process. How do we give the person doing that reconciliation as much as we possibly have about what the person is taking, so that the person doesn't have to remember it or know it, or if they're unconscious, they don't know how to communicate. Got into it is we were prohibited from making it available to independent clinicians, that it can only be made available where there were beds. Because in SureScripts, how they've licensed it from the data sources, there are restrictions in who can actually get access to the data and how it can be brought forward. So even though we had some history, there was some restrictions in even how it could be used. So I think all those things are going to get resolved at some point, because there's a lot of people talking about them. But as an exchange, it's not easy for us right now to say, here is the complete kind of electronic record, because it's coming from a bunch of different spots. It needs to be brought together in a way that's not a mess of duplication and that sort of stuff. So it's on our radar. We're continuing to watch it very closely, and I hope that as some of these things get worked out, there'll be some capabilities that we can make available. But the one, I'm going to go back to where I started and say, and I mentioned this earlier in breakout, the e-prescribing, if you have the e-prescribing app, often you have the ability to get a history from the service that's providing that to you, whether it's SureScripts and what they have throughout their electronic thing, maybe missing some of the edges, but from what we've heard, that is a good primary way as a clinician, at least, to have some view into what's out there that this person may have be taking and picked up.
Other questions? Don't everybody jump at once, come on. Julie, we were talking in the session that Greg and I helped lead earlier today about kind of the not just the breadth of the coverage that GLHC provides, but also the depth, and that so we have some connected members who are pretty deep divers, connected in a lot of different ways. We have some on the other end of that spectrum that are really connected initially so that they could meet those initial meaningful use requirements. From a project management perspective, from a solutions perspective, what are some of the things that you are seeing that we are doing that that might be of interest to folks that will help kind of fill out that range of solutions for them?
Sure. Well, let's see. A couple, I guess, newer solutions come to mind. One being the immunization query solution that we have now. For years, we've been collecting your immunization data and getting that up to state to MICR for you. But now we've got a solution in place where if you want to get that immunization query for your patients, you can send us an electronic query for that from your EMR. We'll process that query and bring back the immunization history for that patient from MICR and present it into your EMR. So that's one of the newer solutions, and those are, assuming your EMR is equipped to handle that, which we're finding that many, I think actually all at this point that we've worked with, are able to handle that. It's a pretty quick turnaround to get that up and running, and certainly very valuable for physicians as they're needing to see that history on a patient so they're not, duplicating immunizations and things like that. So that would be one of the newer ones. Another one, I guess I would say, single sign-on has been gaining popularity like crazy recently. And it's single sign-on to our Viper, to our community health record system. And so within your own EMR, just really by a push of a button, you can gain access to Viper. It's not a separate sign-on. It's you sign on, so if you have Epic or whatever, you sign on to Epic, you get a patient in view, and then typically there's a button or a separate tab within your EMR that you can just click on, and that same patient will come up into view within the Viper application. So you have access within your EMR to all of that community data that's out there for your patient. So.
From a patient care standpoint, what is a perfect world in GLHC? Like, what would you see happening? How far are we from that vision? And what are the biggest challenges that you see getting to that point?
Patient care.
Yeah, so we have seen our role as enabling the provider community to provide exceptional care to the patients that they're serving, as opposed to putting ourselves in line with the patient themselves. Because we don't see anybody, we don't treat anybody. One of the analogies I use is and there's a lot in banking I don't like, but I'll use this one. The ATM networks. It would be really weird if I think likewise, it would be really weird for us, in my mind, for a patient, for us to send them a letter and say, hey, how do you like GLHC? Because ideally, they shouldn't have to know we exist. If the data is getting where it needs to go across the broad healthcare ecosystem in a way that allows them to be cared for in the best way possible, and each organization is going to decide what that experience looks like. There's going to be some Nordstrom experiences out there, and there'll probably be some Walmart experiences out there, and they're both kind of okay. We don't dictate that, but we want to make sure that whatever they need in those environments, we're providing the data necessary to support patient care. So I think we're still a ways from that yet, where the data is just ubiquitously available wherever a patient decides to tap the healthcare ecosystem and say, this is where I am, let me know about ourselves. From a patient portal standpoint, it's an interesting thing in Mandy's conversation, because we saw that very much in meaningful use too, that the meaningful use incentives incented every provider to have their own, and by default fragment the consumer's experience with having to look across all of these things. So we got what we paid for, kind of on that one. I think the question long term is, does a patient want to care about, or does a consumer want to care about us? Do they want to care about the brand and the healthcare system that they interact with most, but have us help give the rest of the data picture, so that whichever provider they go to, instead of being limited to just what's in that one portal, we're providing the rest of the data behind the scenes like we do with providers to fill out kind of what they're doing? Or the portal's going to be, we're going to wake up every day thinking is, how do we take all of the data that's being collected in all this various healthcare entity and be able to funnel it to those places? We have the conversation quite a bit. I mean, it comes up a lot. I think to the extent that, so I know Jeff was here, I'll pick on U of M, and we haven't had this conversation, but so U of M as a brand, as it works with its patients is saying, we want to take care of you. We want to be the organization that answers your questions, that helps you remain healthy and all that sort of thing. So if I put a portal out here and I try and draw the eyeballs of that consumer away from Jeff in order to hit our stuff, there's an element of it that feels experience the patient gets is all of their data being in one place. It's just they're going to the providers that they work with every day rather than having to know to come see, you know, us separately.
Right, or you could be a channel back to them as well for that.
Or back to
the
them.
Informational piece.
Yeah, the other data component that's very interesting is what about the home collected data, home monitoring, the devices, that sort of thing. So there's one element in some argument that would say, well, we can be a clearinghouse where all that data just kind of comes to us. The question from a clinical standpoint is what's meaningful and what do we do with it? How do we break that data that already we have providers saying, I'm overwhelmed by the amount of data, give me information. So how do we turn that? So do those home monitoring devices and those things that are checking weights and heart rates and stuff, how is that going to turn itself out? And I think we're right in the middle of that churn, you know, kind of right now.
Yep. Am I not working? Oh, now I'm working. You set me up really perfectly. I think it's not so much a question as just the patient portal and the ability to have kind of a patient-mediated HIE. Commonwealth Alliance just announced today that they are now going to be granting patients access to all the data that flows through Commonwealth. So I think that the groundwork is being laid for these opportunities. So it was not a question, but really just a statement. So you guys are on the right path.
We've got just a couple of minutes here before we wrap for the afternoon break and then the remaining breakout session. Let me put a question to all of you, and that is just to kind of help inform our team.
I'm sure this will be no surprise to you guys because I've brought this up in the past. Cloud-based. That's really all I have to say. Just your tools be cloud-based. Thank you.
Response to that feedback?
Got it.
Anyone else? There we go.
I'll go again. As a biller in home care, I think the insurance piece is very, and all the elements that go into that for the pre-authorizations particularly, we're struggling getting this from this and that from that source and those types of things. So to have that information readily available, also in Michigan as well, in the home care environment, we're coming up to pre-claim review. So we're being required to have records from all different types of sources that
as panelists or as presenters in breakout sessions today. I want to thank Mandy very much for coming from Jacksonville to be with us as our keynote speaker. Thank my leadership team and all of my colleagues who put a lot of work into developing the breakout sessions and things that happened today. And in particular, I would like to have the members of the planning committee just stand up and be recognized. Chris Ford, Steve Speakers in the back, Mary Graham's over here, and she hates when I do this.